It depends whether the patient is getting therapy in the setting of clinical trial or in the setting of off-trial therapy. So at our institution, we have two frontline clinical trials. One is for younger fit patients, which is combination of 7+3 plus venetoclax BCL2 inhibitor. That data were just published in Blood last December, and the initial cohort of about 38 patients, the data look very impressive. With a very high response rate, above 90%, and MRD negative rates about 80%. So it looks in non-randomized fashion much better than historical data with 7+3 alone. So this study has expanded and is ongoing and has been our frontline therapy for the younger patients. With that said, we realized that there are certain targeted therapies that can be also highly beneficial. For example, menin inhibitors have been presented at this meeting to be highly effective in NPM1 mutated and KMT2A mutated rearranged AML in the front line. So we're part of some clinical trials that investigate that. Also for patients with FLT3 ITD mutations, we do add the FLT3 inhibitors usually in the consolidation setting. So as far as older patients, again, the second clinical program that has been developed at Montefiore is what we call metronomic therapy, that is utilizing very low doses of weekly decitabine and weekly use of venetoclax. So it's really like a fraction of the standard of care dosing. It's metronomic, so it's slow working therapy. So usually it takes about 3 months before patients actually get hematologic recovery and go into remission. But we feel that this is like highly effective therapy, and it allows patients to get it outpatient with much lower readmission rates and less transfusions and less infections. So we've been working on this trial now for quite some time, and there's also like initial data have been reported. It's also effective in the setting of P53 mutated AML that don't do well with traditional dosing. So, but we realize that this is not a curative therapy, so we're moving with the field towards the triplet therapy. So we are developing what we call basket approach, where we're adding targeted agents to this backbone. And we think that this is perhaps better backbone than the standard dosing of HMA-VEN, because it has a room for myelosuppression, so it's not as myelosuppressive as the standard therapy. Therefore, we are adding the IDH inhibitors, FLT3 inhibitors, eventually menin inhibitors to this backbone, and hopefully we'll get better results for our patients.